as we move into an era where we're using PARP inhibitors either as maintenance or in place of chemotherapy, understanding the adverse event profile of these assets is incredibly important. The studies will tell us that patients actually tolerate PARP inhibitors across the board very well, but it does require very active management of the very frequent but low-grade toxicities in order to help patients feel good and maintain dosing for a long period of time. So really paying attention, having an educated office. This isn't something you can just give a bottle of pills off and tell them you'll see them in a month. So active management of the common things, fatigue, nausea, dyspepsia, are incredibly important to helping patients stay on study. One of the essential things to keep an eye on with PARP inhibitors is the hematologic toxicity. For all three agents, talking about olaparib, rucaparib, and niraparib, anemia is the most common side effect really that we see. And they're similar. The grade 3 rate across the board is 20 to 25%, and of those patients, approximately 2/3 end up getting a transfusion at some point. And so those side effects are managed by transfusion, sometimes dose interruptions, and then occasionally dose modifications are required to keep patients on study. But it tends to be a very manageable hematologic toxicity. Otherwise, across all three agents, and we now have data from the PRIMA study, which was frontline niraparib, the rates of grade 3 thrombocytopenia and neutropenia are really fairly low. Less than 6 to 7% for neutropenia, and around the same for thrombocytopenia, a little bit higher for niraparib at 13% on PRIMA. When niraparib first rolled out, it rolled out at this flat dose of 300 milligrams, and it's only once daily dosing and a very potent PARP inhibitor. And so what we learned over time was that not every patient likely needs that much, because we did see much higher rates of grade 3 and 4 thrombocytopenia at the 300 milligram dose level, and it ended up with about 80% of patients bringing their dose down to 200 and some even 100. Something called the RADAR analysis was done of the NOVA study, which identified patients at risk. And so those patients are those whose baseline platelets are less than 150,000, or their weight is less than 77 kilograms. So if they have either one of those criteria, then they're at risk for significant thrombocytopenia and should be started at 200 milligrams instead of 300 milligrams. If they have neither of those, then their risk of severe thrombocytopenia is about 13%. So it's a little bit different than the other PARPs, but very manageable with what we call the weights and plates dosing. And again, that came from the NOVA study. And as soon as that result came out, the sponsor, Tesaro, amended the ongoing PRIMA study, kind of partially through, to incorporate this individualized dosing for patients. And so that data was presented at the Society of Gynecologic Oncology meeting in 2019, just looking at the pre and post amendment hematologic toxicities. And you can kind of compare it to SOLO-1 because it's frontline. And they're very similar, still a little bit more thrombocytopenia, but not a tremendous amount, and certainly a vast improvement over what was seen before. So the individualized dosing would appear to make the hematologic toxicities relatively similar across the three drugs. The key piece of data that's missing, of course, is the efficacy data from PRIMA, which hopefully will confirm that the individualized dosing did not impact efficacy, which quite frankly, none of us think that it will, but that's really a key piece and will really solidify individualized dosing for niraparib as the standard of care for maintaining safety, but also maintaining the ability of patients to remain on study and benefit.